Ladies and gentlemen, thank you for standing by, and welcome to the Adverse and Serious Adverse Event Reporting in CTN trial. As a reminder, today's call is being recorded. If you need technical assistance during today's call, please press star then 0. As a reminder, all lines will be in a listen-only mode during today's presentation. At this time, I would like to turn the call over to your host, Ms. Lindblad. Please go ahead, ma'am.
Okay, thank you. All right, I just wanted to let everybody know, if you have a question at any time, feel free to press star 1, and the operator will open up your line to speak with the presenters, Dr. Robert Lindblad and Maria Campanella. Bob, I'll go ahead and turn it on over to you. Oh, wait, one more thing. I wanted to remind everybody or to let everybody know that they can press F5 for a full-screen view of the PowerPoint presentation, and if they want to come back out of that, they can press F5 again. All right, Bob, it's all up to you.
Hi, everybody. There may still be some other people that will be joining us as we go along, and again, we wanted to make this as interactive as we can, so feel free to ask questions as we move along, as Liz had mentioned. If we start getting behind, we may limit questions just to the end. We've divided it into 6 lessons. I will present the first one. Maria will do the second. I'll do the third, and hopefully by the time we get to the end, you'll all still be awake. So what we're going to talk about today is adverse event and serious adverse event reporting in CTN trials. Both Maria and I are charged with the safety monitoring for these trials. I do a lot of medical monitoring with other networks and in other trials as well, too. And so I'm sort of pooling some of that information to present it with the slides that we're doing today as well. So the seminar, the intent of it is to help everybody identify, assess, and report adverse events and serious adverse events in the types of clinical trials that we do, which are primarily behavioral research trials. Clearly, there are some trials with medication interventions as well, too, and we'll talk about that as we go along. At the conclusion, we're hoping that you will understand why it is that we report safety in clinical trials, that you can distinguish between an adverse event and a serious adverse event, and describe adverse events and serious adverse events more accurately and more succinctly. Each lesson are going to try something new with this presentation, where we'll put some polling questions together. They're fairly simple questions. They're relevant to the lesson that we went through. So at the end of the first lesson, there'll be several true-false polling questions. And you'll be able to actually click on that on your screens, and then we'll see the answers as you all respond to that. So you have to be on a computer to do the polling questions, and then we'll move back to the main slide presentation afterwards. And we're hoping, if this seems to work well and sort of breaks up the presentation a little bit, that we can incorporate this in future ones as well, too. So we'd like your feedback as to whether or not you think that this is useful. So this is the first polling question. So this is just asking what your experience level is with adverse event reporting. Now, those of you that are in a big room where you have multiple people listening in, you're going to have to come to a vote fairly quickly to do this, because we won't stay on these for that long. So it looks like out of the group that's on here, probably about a third of the group is very experienced with adverse event reporting. About a third or a quarter are saying some experience, quarter very little experience, and 15% with no experience. So we'll try and, as we go through this, try and blend the information that we're providing to make it make sense to this group, but it's obviously a pretty varied group. So Liz, we can go back to the slides. So the outline for the training today, Lesson 1, we're going to just talk about safety monitoring in an overview, why we do safety monitoring and some of the issues surrounding that. Lesson 2, which Maria will present, will discuss adverse events and serious adverse events, differentiating the two. Lesson 3 will be characterizing the adverse events. I'll present that section. Lesson 4 will be assessment. Lesson 5, documentation and reporting. And then Lesson 6, which Maria will do, will be the follow-up reporting for adverse events. So in the Lesson 1, we'll sort of try and cover why it's important to monitor safety in clinical trials, some of the challenges that people face when they are trying to do safety reporting specifically in behavioral trials, what's our role, and what's the role of the research staff. So the first question, why monitor safety in a clinical trial? There's lots of issues that have happened over the years where people involved in clinical trials, essentially their rights were not protected. And out of that came the ethical responsibility to monitor safety in trials, and that's where informed consents came from as well, too. There are regulatory responsibilities according to both FDA and ICH guidelines and good clinical practice. And even though our trials are rarely regulated under IND, a couple of them have been, they are all still responsible for conducting clinical trials under good clinical practice. And there's a federal mandate to conduct trials under good clinical practice based off of our trials are funded through federal government dollars. So essentially all clinical trials require safety monitoring of some sort. How that is tailored to the individual programs is what we'll discuss as we move forward. So most of the current standards and the standards that people understand with safety reporting are derived from FDA guidelines, ICH guidelines. ICH is the International Conference of Harmonization, which is grouping of both FDA, European, Japanese, Australian regulatory agencies to have common documents that can be used internationally. So basically, anybody conducting clinical research is obligated to look out for the safety of the participants, and that gets into reporting of safety events. You need to assess the risk associated with the trials that you're conducting, and also look at the vulnerability of the patient population that you're dealing with in your clinical trials. So in general, it's fairly clear the reporting strategies for medication trials, though even in those trials there are a lot of variations that can be introduced into those trials and into the protocols that are using medication interventions. There's less safety information and less knowledge in terms of reporting strategies and behavioral interventions. And there's less knowledge about the risks related to behavioral interventions, and if there are even risks at all associated with that. There's less consistency in behavioral trials as well, too, in terms of the type of safety data that should be captured. Again, in medication, especially licensing trials, there's fairly standard reporting of adverse events and serious adverse events, and the definitions that are used for those are relevant primarily to those types of trials. When you're in trials that are not for licensure and trials that are not involving any pharmaceutical intervention, it's less clear in terms of how to adapt strategies to be effective for safety reporting. But the same premise still holds true, that safety monitoring must be conducted in trials, and it should be relevant to the type of trial that you're conducting. So what are some of the challenges inherent to behavioral trials? Behavioral trials, and especially the trials in the CTN, deal with a vulnerable, largely underserved, and potentially misunderstood population, so that it's actually, that makes these trials a little more risky than perhaps other populations. Their access to health care, their ability to protect their own interests may be more limited than in the general population. The concept of vulnerable population is also true in pediatric and adolescent trials, where there's more concern about ability to consent and understanding consent as well. So there are many different types of vulnerable populations, but I think the populations involved in the CTN trials in general would be considered a vulnerable population group. And then the other challenge is really behavioral trials. We're looking for changes in human behavior, and it's hard to quantify that. It's hard to measure, as we've all struggled with, the outcomes of the interventions, much less the safety risk associated with those interventions. It's much easier to quantify laboratory values or urine tests or other things like that versus the behavioral interventions. But the same premise goes back, and that's why this is written several times, that it's still a requirement that there is safety monitoring within the behavioral trials as well. And I think the challenge becomes, how do you tailor that to the trials that you're doing based off the population that you're studying, and based off the risk that you believe is inherent in the trials. So I think the next piece is really talking about the language of safety that's in clinical trials, and this language is essentially universal, and it really doesn't matter if it's a behavioral trial or if it's a medication trial. I think if we all stick with the same types of language and description, it serves us well in terms of reporting our results in the literature, that people can understand and interpret the type of information we're trying to provide related to safety. So the language that's specific for safety reporting are adverse events and serious adverse events, both of which we'll define in the next section. Verbatim, which is really the very succinct term that's used to describe the adverse event. It's usually a 2 to 3 word term that is the designation of that adverse event, not so much the description of the entire event or events that surrounded the reported adverse event. We have to determine the severity of the event, and there are guidelines and the protocols in terms of how to do that. The relatedness to the study intervention, or if there's a medication to the study medication, or if there's a specific delivery, could be a relationship to the delivery. Expectedness, whether this event was considered expected or not. And we also have to come to a resolution for that event, where that event is considered resolved or stable. So the language that is used is somewhat different than the language used in the practice of medicine. And I think monitoring safety in clinical trials has regulatory implications, reporting implications, both to IRBs, DSMBs, FDA potentially, sponsors of the trials as well too. But it doesn't always match that well with how we practice clinical medicine or see patients in a private practice setting. So it's some of the terminology is just a little bit different. An adverse event is not necessarily a side effect of the medication. It's an event that occurs while somebody is involved in a clinical trial. If an adverse event is considered severe, which we will go into in terms of grading events, it doesn't necessarily mean it's a serious adverse event. By the same token, you can have adverse events that are graded as a mild adverse event but still require hospitalization, which would then designate it as a serious adverse event. So the severity grading does not necessarily correspond strictly with whether or not an event is a serious adverse event or not. Expectedness of an adverse event is really defined by the investigator's brochure, and if there is not an investigator's brochure because there's no study drug intervention, then it's defined by the protocol, the consents, the information that's available about the intervention and what the risks are associated with that intervention. But expectedness is not based off of somebody's clinical judgment as to whether or not they expected that event to occur within the trial. It's a much more rigid definition than that. Positive findings at baselines are not considered adverse events, and if that event is noted during the trial, it still is not an adverse event unless that event becomes worse during the context of the trial. And a worsening of a baseline condition would be considered an adverse event. So one of the struggles that I see across all the trials that I do and across all the institutes at NIH and even in commercial work is that there's a difference between practicing clinical medicine and practicing research. And they struggle with that in terms of making designations in terms of relationship or severity and expectedness because they're used to looking at these parameters on a clinical basis in their day-to-day practice. But these terms have specific meanings in the context of clinical trials, and it's always important to remember that as you're trying to make those designations within the context of a clinical trial and put that hat on essentially in terms of evaluating these events versus your clinical hat that sort of tells you that perhaps this event really isn't important and it doesn't need to be reported. So everybody that's involved in the study is really responsible for ensuring participant safety. So it's really the monitoring for adverse events and the reporting of those adverse events that helps to guarantee the safety of participants in trials. And it starts with whoever it is that's interviewing participants to elicit events, the actual taking that information and putting it into a data system or transmitting it to other people that have an interest in reviewing that information, and then processing it to the various regulatory bodies, whether or not it's an IND study, it may go to the IRB or to the sponsor or to the DSMB. So our responsibility in this overall scheme of things is to review, track, and clarify reports of safety-related events. We hopefully provide some guidance to the study teams with regards to safety and helping to resolve some of the challenging problems that are faced on a day-to-day basis. And we're also responsible for shepherding reports to the regulatory entities, which includes primarily the sponsor of the study, for the CTN studies, the DSMB, and for studies that are conducted under IND to the FDA as appropriate. So the study team safety responsibility is complete and document the baseline assessments. By having a good baseline assessment, you have an understanding of what are pre-existing conditions. So it makes it easier to assess if a symptom or an event that occurs is actually new or if it's just consistent with what they have experienced at their baseline. You need to query participants on a regular basis when they come in for their visits to see if they've had any untoward effects or any problems that have occurred within the time period from when they were last seen. You want to try and utilize the safety terminology that we discussed earlier in terms of describing the events, and we'll go through some of that more in detail. You want to submit this information in a timely manner as defined in the protocols. You need to continue to update the event if the situation changed relative to the event, and hopefully come to a resolution for the event as well, too. And make sure that you've provided that documentation into the data system. So I've used this slide a lot. I mean, from my perspective, we're sort of all in this boat together, and we're not really in separate places at all. And that includes the sponsor of the trial, that includes us at the CCC, that includes you at the site. And if we all do this together and sort of maintain our parts of this process, I think we do pretty well. But it only takes one part of that process for the next slide to occur, and essentially the whole boat goes down. And we've seen this all in popular reports in clinical trials. If a disaster occurs in a trial, everybody goes down on that ship that was involved with that trial. And so it's important that everybody maintain their role, their documentation, and their vigilance to safety events that occur in clinical trials. So now we're going to do a couple polling questions. And again, the goal for this is sort of to break up the presentations. And a lot of these are trying to recap some of what I had talked about initially. So the first one is behavioral trials with no medication intervention do not require safety reporting. And now you're giving me a false sense of confidence now. So in response to this, there's one participant that said that behavioral trials with no medication intervention do not require safety reporting. All trials, whether it's behavioral or medication-based, do require safety reporting. And we'll talk a little bit about how we can modify or customize safety reporting to the various types of trials that we're involved with. We can go to the next one. Regulatory requirements for safety reporting are based on the practice of medicine. So one of the points that I was trying to make in here is that safety reporting, sort of the knowledge of safety is tied to the practice of medicine, and you have to basically be a clinician, you know, to conduct clinical trials that are appropriate in the type of practice that you're in. But the rules for safety reporting, determination of severity, and expectedness have very little to do with the practice of medicine, and that's where things start to differentiate. And the biggest pitfall that I think people run into is they use sort of their clinical medicine assessments to look at adverse events. And by doing that, if somebody, participant comes in and they're intoxicated, and so the clinical assessment might be that well, this patient population is always intoxicated. This is nothing unusual for somebody involved in this trial. Therefore, it's a baseline condition. That thought process is essentially irrelevant in a clinical trial, because what's pertinent in the clinical trial is that individual participant. And so you would have to look at that baseline assessment for that participant and say, in fact, was it documented that this person has intoxication, you know, 3 times a week or 5 times a week or some frequency, and the event that you're seeing is really no different in this participant than that baseline assessment. If it's different, it's an adverse event. If it's not different, it would not be considered an adverse event. But it really doesn't matter what the general feeling or gestalt is about the types of events that you might expect to see in the population in general, which is more what your clinical impression would be. So we'll go to the next one. So the medical monitor is solely responsible for the safety of the clinical trial. So I'm hopeful the boat image was effective, because I don't know how to drive those boats anyways. But it's really all of our responsibilities in terms of the safety and of the participants in clinical trials. If the people that are at the site seeing the participants are not identifying and reporting adverse events, the trial could look incredibly safe, and there could be horrible things going on. So that it starts there, and it just goes through a whole process of evaluation and review. Is there one more? Yeah.
No, we'll go back to the presentation.
Okay, so that's sort of the completion of this first lesson. So we start moving into lesson 2. I'd like to open it up for questions if anybody has any specific questions in the information that I presented.
Thank you, sir. If you would like to ask a question via the phone lines, please press star then 1 at this time. The voice prompt on your phone line will indicate when your line is open. Once again, that is star 1 if you would like to ask a question.
Okay, so I'm going to turn it over to Maria, and she will go through lesson 2.
Hello. Thanks for hanging in there. Lesson 2, adverse events versus serious adverse events. Now you know you have a responsibility to report safety events, but sometimes it's hard to know which events are adverse events and which events move on to become serious adverse events. In clinical trials, it's pretty well documented that AEs, adverse events, are chronically underreported. And sometimes this is because there are a lot of variables, a lot of reasons why. It might be because the participant is not very clear or very forthcoming about events that have occurred, and this may be because they don't recall when they're in front of you at their assessment, or because they don't feel comfortable revealing that information at that time. And sometimes it's because the clinician or the person doing the assessment isn't asking the right questions. And sometimes it's a combination of the two. But it's crucial in clinical trials that you're able to recognize adverse events when you're interviewing participants. Adverse events can be identified through a variety of tactics. Of course, you've got your direct participant discussions, direct observations of the participant. You can look at the facial expressions, and during an assessment, use what is sort of your clinical judgment to assess what the person may or may not be telling you. You can listen to reports from family and friends of the participant. They may call you and tell you that something has happened, but keep in mind, too, that you can take information from them, but just remember that without the participant's written permission to do so, you can't give that information out to them. If they ask you questions, you can't answer questions about the participant. You may read about something to do with the participant in the newspaper article, in particular with like a death announcement. You may have a confidential discussion with another member of the research staff or with outside providers. And again, if the permission is given by the participant to do so, you can discuss it with outside providers, and sometimes that's what a participant would prefer. So how do you decide, SAE or AE? We'll go through a definition of what each of those is, adverse event versus a serious adverse event, how you can work to identify and differentiate between the two. As Bob has mentioned earlier in the presentation, an untoward event that occurs to a participant during the course of a clinical trial, whether or not it's considered related to the trial, whether it's related to the intervention itself, or whether or not it's clinically significant, If it's something that occurred to a participant during the course of their participation in a clinical trial, it is considered an adverse event. And there's that funny word in there, untoward. So what does that mean? It's literally defined as anything improper, unfortunate, or causing misfortune. But it's very simply put, any event that occurs that's out of the ordinary. So something that happens to someone while they're on trial. So how do you know when to kick it up a notch? How do you know when it goes from being an adverse event to a serious adverse event? And this is when you need to really look at the protocol itself. Not all adverse events necessarily become serious adverse events. The serious adverse event is always an adverse event first. So again, looking at your clinical protocol, or rather your protocol, and keeping in mind what the definition of a serious adverse event is it's an adverse event that either results in death, is life-threatening and therefore could result in death, results in hospitalization or the prolongation of an existing hospitalization, results in a persistent or significant disability or incapacity, results in the birth of a child with a congenital anomaly or a birth defect, or if it requires intervention to prevent one of the above outcomes. So an AE becomes an SAE once it meets those defined criteria of what constitutes an SAE in the protocol. The protocol is the one that defines what the adverse events and the serious adverse events that require reporting are. Important things to remember with regards to adverse events. This is where you really need to interact with the participant, ask the participant a little bit more detail about when the event began. That would be considered the onset date. If they can't remember the exact date when it began, then you use their best assessment of when the start date was. Then the outcome date, the date that the adverse event resolved, is the date that the participant says they are no longer been affected by the adverse event. The main thing to do is to always look at your protocol for specific definitions of the adverse event and serious adverse event. Within the CTN, there are various protocols that define adverse events and serious adverse events differently. For some of our protocols, admissions to a hospital or freestanding residential facility for detox are not considered SAEs. For other trials, once a participant is admitted into a hospital, it is considered an SAE. For instance, also going to the hospital for scheduled labor and delivery or an elective surgical procedure is not considered an SAE. Those admissions are only reported as adverse events. For other protocols, for instance, CTN 27, there are very specific definitions about adverse events. It's a trial that deals specifically with lab values. So, for instance, if the event, the protocol is what is defining. If their liver function tests increase more than 10 times the upper limit of normal, it becomes an adverse event. But until it reaches that parameter, it's not considered an adverse event. And the other two examples, the bilirubin and the INR, are the same. The protocol is very specific with the definition of what and when a particular value becomes within that parameter of reporting it as an adverse event. Sorry, I skipped one there. In behavioral trials in particular, some social or situational events are often not categorized as adverse events. And again, this is because perhaps it's characterizing the population a little bit more. It's defining what is anticipated or not. And some examples of this that are pretty clear-cut are incarceration, or if an individual is evicted from their home, or they lose a job. Even though these are adverse to the participant, they're not necessarily adverse events. But again, this is what's characterized by the protocol itself. I mean, you have to go back and look at the definitions within the protocol to see what would be considered adverse events and not for that particular population.
And ma'am, prior interruption, we do have a question.
Sure.
Caller, please go ahead.
Hi, this is Paul Joaquin with NIDA.
Hi.
I just want to try to make sure I understand the difference between sort of the generic definition of a serious, how an adverse event becomes an SAE, and when the protocol defines when an AE becomes an SAE. Is there one that overrides the other, or is it whatever the protocol says is it and nothing else? In other words, you've got two rules. The general rule that says, hospitalization is an SAE, all the others that you had in that slides. But on the other hand, what the protocol says, an AE becomes an SAE. So are there some rules that override other rules?
So Paul, this is Bob. The protocol really defines the parameters. So the SAE rule set in terms of what determines an SAE, such as the hospitalization, are the general guidelines that are basically what's on the MedWatch form and what's defined in the regulations for IND studies. But even under IND studies, a protocol can specifically delineate variations to that rule set. You can choose to add other events to the SAE list. For instance, in NEI studies, they will add all malignancies are by definition a serious adverse event, even if it's a basal cell carcinoma. You could also limit SAEs by saying that SAEs or hospitalizations that occur for an elective medical procedure would not be required to be reported as an SAE within the context of the study. The protocol is really the area where you have some flexibility to tailor your reporting to make it appropriate for the type of study that you're conducting. And the protocol is vetted through multiple different bodies that have a vested interest in the safety, which includes the sponsor, a DSMB, if they exist, the IRB at each site. And each of these bodies then have responsibility to agree to that safety reporting plan or not. And so you may get input or have to modify those plans based off of the safety concerns that any of those review bodies would have. So, it's an important issue, but the protocol is the document that defines the safety reporting for the clinical trial, and it will usually define SAEs based off the generally accepted criteria, and then have the protocol can be modified to tailor the reporting to the type of clinical trial that you're conducting. But that has to be vetted through an approval process, and the minimum of that is the IRB at any institution, because that's where that protocol will be instituted.
Okay. Thank you very much. That answers my question.
Okay, in this slide is an example, for instance, of a participant being incarcerated after starting a fight. And oftentimes, the focus becomes on the incarceration, and in fact, it's not necessarily the adverse event that's happened. There's something that's I guess, the causative factor of this incarceration. And so you want to look a little bit deeper, and possibly, it may be in this case, increased aggression, that the participant was in a fight and incarcerated as a result of being in that fight. What was the cause of the fight? Increased aggression. Another example would be, for instance, the participant reports feeling depressed and anxious because they lost their job. Again, it's easy to focus on the losing their job part, So what we need to focus more on is the anxiety and the depression, not so much the losing your job. That's sort of the outcome of the adverse events of depression and anxiety. Pregnancy is an interesting question that comes up very frequently in clinical trials, both medication trials and in behavioral trials as well. In most of the CTN trials, although pregnancy is a safety consideration, and it's an important safety piece in clinical trials, especially where the study intervention is medication, but even when it's not, we like to know that information, that data, and rather than, in the more recent CTN trials, rather than try to capture that information as an adverse event, even though it is something that is an untoward occurrence during the course of the trial, it's actually captured on a separate CRF. But it is treated as safety information, and it is looked at as such. And so for that reason, it needs to be followed through outcome, just like an SAE, all the way through resolution, whatever that resolution may be. And there are a lot of outcomes that can apply to a pregnancy. So being as specific as possible with regards to that outcome, if it was a miscarriage, if it was an elective termination of a pregnancy, if it was ultimately a delivery. It's very important to know what the outcome of those pregnancies are. We can go on to the Lesson 2 polling questions. All SAEs, are AEs. This was sort of in the beginning of the slides where we talked about all SAEs are first adverse events that then they go on to progress to become serious adverse events. Next question. The protocol defines what constitutes an adverse event and a serious adverse event. This question was really addressed in the discussion between Paul and Bob a few minutes ago, that it is the protocol that pretty much determines ultimately what the definition of the parameters within that trial are. Next question.
If you would like to ask a question, please press star 1. And we don't have any right now.
Okay, thank you. AEs are typically over-reported in clinical trials. Looks like everybody got that one. They are chronically underreported. Pregnancy must be reported as an SAE in a clinical trial. And again, pregnancy is one of those things that it is an untoward event that occurs during the course of a clinical trial. Sometimes in some clinical trials it's reported as an adverse event unless the person becomes hospitalized for preterm labor or some other event that occurs that causes, a reason for an admission to a hospital. More than likely, the pregnancy would not become a serious adverse event. Okay, I'll turn it back over to Bob. Thank you. If there are any questions, please press star 1.
And it appears we have no questions.
Okay, so this next section is characterizing an adverse event. So we'll talk a little bit about verbatim description, what that really is and what that means, and how that should be recorded, determining severity of an event, relatedness, and expectedness. The verbatim description. So this is sort of a challenge. It seems simple. You know, somebody comes in, they tell you they were vomiting, and so you put down vomiting as the adverse event. It's great when it's that simple. What we tend to see, and again, this is across all trials, instead of vomiting as the verbatim or the name of the adverse event, what we see is the participant was feeling sick to their stomach, and they decided they threw up once, and that may be the whole verbatim. And it becomes very difficult to understand at our end when we're not really seeing the participant what the actual event is. So verbatims should be a very succinct 2 or 3 word description of the event. So you need to sort of sort out, and we do that all the time taking clinical histories. You have to sort out sort of a long paragraph narrative and get it down to one key thing that occurred, or maybe it would be 2 key things that occurred. So if you get a little bit stuck, I mean, it's easy to check with the clinician at your node or other resources that you would have. You can also try and get a hold of us as well, too, through email or a phone call. It just takes sometimes some practice to narrow down sort of these long descriptions into the appropriate word that characterizes the event. So again, the verbatim should be simple and accurate, preferentially 2 to 3 words. If you know what the diagnosis is, that would be great, and recording the diagnosis would be appropriate. Oftentimes you don't know the diagnosis and you just know symptoms, so that you would record symptoms. You really want to record single terms, so it becomes an event, and we'll get into what we do with adverse events as they're reported. But it gets into a problem when a verbatim is recorded as fever, nausea, vomiting, rash on foot, because you can't take those 3 separate things and put them into a single event that you would then code for structuring basically the reported adverse events in study reports and comparing across clinical trials as well. So it's really important that you report single events, or that each event is reported as a single term. And this gets important for MEDRA coding. MEDRA stands for medical, is the MED, dictionary for regulatory activities, and this is the accepted essentially dictionary for coding adverse events into a common language. So it's a five-tiered system. The first tier has about 60,000 terms, and the last tier has about 26 system organ classes. So the MEDRA coding is really why it's important to record verbatims as single events. And so if a person comes in and gives you a long history, embedded in that history may be 2 or 3 separate adverse events, and that's fine. You would enter each adverse event as a distinct event, even if it clustered around a given history that you get from a participant. But it really ties into being able to take that adverse event that's reported, being able to match it to a term in this dictionary so that these events are then organized in a way where the adverse event information from this clinical trial can be compared across other clinical trials that also were coded using MEDRA coding, and you can characterize the events in the same way. So that's the verbatim portion. So the next part of characterizing the event, so now we have a nice short name for the event, a 2 to 3 word description of the event as a verbatim, and then we want to grade the event in terms of the severity. Sort of how bad was it? You know, is it grade 1, grade 5? The important part with this, and we'll talk about the severity grading in a few more slides, the important part is to remember that severity and seriousness do not mean the same thing. This mistake is made over and over again in clinical trials, and the best that I can figure out is they both start with SE, and so people interchange them all the time. It's incredibly important to keep them separate. The only time grade has relevance to seriousness is grade 4 and grade 5, because if you remember the definitions of a serious adverse event, death by definition is a serious adverse event, and a life-threatening event by definition is a serious adverse event. So grade 4 and 5 events are severity graded as grade 4 and 5, but also meet the definition of a serious adverse event. Grades 1, 2, and 3 do not meet the definition by themselves of a serious adverse event. So grade 1 is considered not so bad. So it's sort of transient discomfort. Rarely would somebody with a grade 1 event get hospitalized, and especially in today's medical environment, that's pretty uncommon. Grade 2 events, getting a little bit worse. There's some limitation in activity associated with it. May require some intervention as well, too. And there are some number of grade 2 events that do require hospitalization as well. So just because it's a grade 2 event does not mean it cannot be a serious adverse event if it was associated with a hospitalization. So grade 3 is getting worse, where there's marked limitation in activity. Usually there is medical intervention required, and hospitalization oftentimes can occur with a grade 3 event. Grade 4 is life-threatening, usually requires significant intervention. Hospitalization is almost always required for life-threatening events. Though sometimes you can have events like an anaphylactic event that requires prompt treatment with epinephrine and other interventions, may require an emergency room visit but not require hospitalization. That event could be considered life-threatening, but actually resolved without hospitalization. Grade 5 events are fatal events. And, you know, when that event is described, death is really not a great verbatim to use. Generally, you want the cause of death as the verbatim. So if somebody died from a heart attack or a myocardial infarction, that would be the adverse event, and the result of that adverse event is death. The problem you get into sometimes is you don't know why somebody died, and so you may see something in the newspaper announcing a death, or a family member calls up and says they died, but they don't know why. So death may be the best that you have to put in temporarily until you get more information, or potentially you never get more information than that. But your goal is to try and put the cause of death in as the FAE, not death itself. So if you struggle with severity coding, again, this is subjective, and this is determined by the clinicians or the researchers that are seeing the participant. That you have to make a designation of severity. You do have support of the medical clinicians at the site, and certainly you could consult with us at the CCC as well, too, if needed. And the other thing is there's nothing that's perfect about this either. You're using your best judgment based off the information the participant is giving you, so that you just use your best judgment and base it off of the history that you obtained. So the next section of characterizing the event is looking at relatedness. So we have the verbatim, we have severity grading of it, and so the next thing is this event related to the intervention or not? So this determination, again, is done at the site. It's not done by myself. It's not done by the sponsor. It's not done by FDA or the DSMB. It's done by the person evaluating or responsible for evaluating the participant at the site. So in a regulatory sense, the relationship is really a binary choice. It's either associated with the intervention or it's not associated with the intervention. But in a clinical sense, people have a harder time dealing with that binary choice. So we sort of subdivide that category of associated into three smaller categories where it's definitely related, probably related, or possibly related.
Point of interruption, sir. We do have a question.
Sure.
Caller, please go ahead.
Bob, hi, this is Paul again. Sorry for the time lag between pressing *1 and then he asked the question. But in terms of the seriousness and the severity, can you give an example of a severe event that's not serious and a serious event that's not severe?
I've had people, for instance, that broke a hip that was considered moderate in severity, but required hospitalization for fixing the hip. Now, one could argue to say, well, that should have been coded as a grade 3 severe event, but it was graded as a grade 2 moderate event and required surgery. So that's one example of that type of event. There are other examples where somebody is admitted to the hospital for pneumonia that could be treated on an outpatient basis, but for social reasons was admitted to the hospital preferentially, where the pneumonia was considered a moderate event but not a severe event, but it still required hospitalization. By the same token, that pneumonia example on the other side could be considered a severe event in a younger person, and that person was treated with IV antibiotics in the hospital, discharged home, and treated with oral antibiotics at home. So it could have been graded severe. Allergic reactions as well could be graded as a severe event and then discharged from an emergency room. And emergency room visits in and of themselves are generally not considered hospitalizations. They're considered an outpatient evaluation similar to a physician's office visit as well, though the care is a little more intensive. Typically, hospitalization refers to an inpatient admission, which is beyond sort of that outpatient designation of a 23-hour sort of outpatient observation period in a hospital setting. It's actually an inpatient admission.
Thank you.
Okay. So getting back to associated or related or unrelated, so the associated we define into three categories, which is either definitely related, probably related, or possibly related. What I think is important in terms of relationship, there are two things that really drive this. One is a temporal relationship. If the person never got the intervention, there's no way it can be related. If the person got the intervention a year ago and the event occurs at the end of the trial, it's pretty unlikely that that's going to be related to that intervention unless there's some plausible or known response pattern that you would expect that type of reaction to occur a year after the intervention. So temporal relationship or temporal sequence to the timing of the adverse event relative to the administration of the intervention is important in terms of determining association or relationship. The less reasonable that temporal sequence, the more unlikely it is that it's related to the intervention. And also the concept of a response pattern that is either known with this intervention or not. And these criteria get difficult in behavioral trials, and I think everybody struggles with this to a degree. But I think, you know, there's some cases that may be obvious where there is a part of the study intervention, a group session or something, where somebody has a significant reaction at that session storms out, and acts out outside of the clinic or at home, and there's a strong feeling of the temporal relationship to the intervention that was conducted in the study and this event of aggression or acting out behavior, so that you may consider that type of event related to the intervention that was done. Whereas if the person left and seemed perfectly okay, and then some event occurs a few days later, you may be less inclined to consider that clearly related to the intervention. But these areas are gray, and I think it is dependent on the site and the investigators to make that determination based off their best clinical judgment. And this is where clinical medicine does interface with clinical trial practice in terms of determining relationship within the boundaries of a temporal sequence and a response pattern associated with it. So the other option you have is not associated, and that usually implies that there is not a temporal relationship that seems to make sense or seems reasonable, and there are other reasons why you believe that this happened that have nothing to do with the study intervention that was done. I've got to back up a minute here. So expectedness is sort of different, and this is the one that definitely gets away from clinical medicine. So expectedness is really pretty clearly defined as being expected relative to descriptions of the intervention and what either the participant knows about that intervention or what's recorded in the protocol about that intervention. So in medication trials, you would use a package insert if it's a licensed product, or you'd use the investigator's brochure. And within those documents are listings of the types of adverse events that have occurred in clinical trials using that medication product. And if your adverse event is in that list of adverse events, then that would be considered an expected event because it's already been described in a clinical trial for the use of that product. The one time that's different is if the event that you're seeing is much worse than that described, same type of event, but just worse. So if liver function test elevation is reported with a certain medication, and that's what you see in your trial, that would be an expected event. If the person in your trial has fulminant liver failure and cirrhosis, and the only thing that's described in the package insert or the investigator brochure is an elevation of liver tests, then that event is no longer expected because the severity is worse than what is described in the investigator brochure or the current package insert. So, but these are very specific locations to look for an event to make a determination as to whether or not this event is expected for this intervention. In behavioral trials, where there is no medication intervention, that's very difficult to define because there's very little literature that says these are the expected types of events for the intervention that we're performing. So we have to rely not so much on an investigator brochure, because there is none, or a current package insert. What we rely on is the protocol and the risks described in the protocol, and we'd also rely on the consent and the risks that are given to the participants in this trial for participating in the trial, what, to the best of our ability as the group or the investigators, believe are risks associated with the interventions in this trial. And that's why those areas are important, both in the consent and the protocol, because they help define what we expect to be potential outcomes or bad outcomes for involvement in this clinical trial, and it helps determine what is considered an expected type of an event, or if the event we're seeing falls outside of that. So now we'll switch over to a few poll questions for 3. So the first question, the verbatim should be as detailed as possible. is really fun to watch this stuff sort of grow over time. Eventually, we may hide the polling results so people can't sort of do this mob mentality and feed off of each other's answers. So the verbatim should be as defined as possible and succinct, but it should be a 2 or 3 word item. So it should not be detailed, but it should be very specific. There are 2 areas for detail. One area is if it's a simple adverse event and you need to add more details, there is usually a comment section on the adverse event form where you can add details. Those comments are really not part of the analyzed database. The verbatim is what would be coded to the MEDRA coding. But it can provide useful information if there's a reason to provide that. If it's a serious adverse event, you have your verbatim, which is sort of that 2 to 3 word name of that serious adverse event, and then you will have your event summary, which is the detailed area where you'll give the history and the description of the event. And as Maria pointed out too, all SAEs, serious adverse events, are adverse events. Every adverse event every serious adverse event starts as an adverse event, and that's why those names of those 2 things, those 2 events, are the same, because it's all the same event. We can go to the next one. All grade 3 severe events are serious. And that's correct. I mean, we talked about that at some length, that their severe events do not define serious adverse events. So the severity grading is only relevant for a serious adverse event if it's a grade 4 or grade 5 event. We'll go to the next. The relationship of an event to the study intervention is driven primarily by the temporal association to the intervention. So this is split. I mean, there are 2 things that define, relationship: temporal association and sort of known response pattern. But in general, the temporal association is the dominant driver for determining relationship. And the example I gave is if it occurred before you got the intervention, it clearly is not going to be related to the intervention because there's not a temporal sequence associated with that. But the other important thing is the known response pattern for the type of intervention that you're providing. The next one. Whether an event is expected is based on medical clinical judgment. So determination of expectedness is one of those areas that is definitely not based on medical clinical judgment. It's based off the more written descriptions in either an investigator brochure, a package insert, the protocol, or the consent. The place where people get into the most trouble is making sort of subjective decisions about expectedness based off of sort of clinical judgment, their knowledge of the participants in the trial or their general experience or things like that. And in the context of reporting in clinical trials, that generally will not be in the same direction as would be decided based off of the material that's available to review. So it's very important that determination is done based off the materials in the clinical trial, which is, in our trials, for the most part, the protocol and the informed consent. but some of the trials have investigational agents as well. I think that's the last one. We'll go to the next section. If there are any questions at all.
Once again, ladies and gentlemen, that is *1. And I don't see any questions.
Okay, we'll move to the next group.
Oh, we do have a question, sir.
Uh-oh.
Please go ahead, caller.
Hi, this is Karen from Willamette Family. We have a question here.
Sure.
Will the sites have access to the MEDRA coding so that will help us with the verbatim portion?
The coding is done, so after you report on your adverse event, that is then coded at DCRI, and we do that type of coding here at the CTC as well in different clinical trials. That usually occurs maybe 3 months or 6 months after that event has been put in. It occurs at some interval, whether it's monthly or every 3 months or before the DSMB or something like that. But that coding is what generates DSMB tables, annual report tables that would be submitted to INDs. Whether or not there's a way for you to see that coding is I don't have an answer for that. Typically you don't, but we do a lot of MEDRA coding here and looking across multiple trials. If you have a clear verbatim that is essentially 2 to 3 words long, it is pretty easy to MEDRA code that. There's very little that can't be coded. There are enough MEDRA codes to find something that matches reasonably well. And the goal of MEDRA coding is to not guess at what the person meant when they recorded an event. And that's where being very specific but succinct is important, and it generally works well. But I don't know if there's a way for you to see that. There's certainly resources online in terms of looking at sort of MEDRA terms and things like that, and that can certainly discuss that more at some point as well, too, if there would be an interest.
Okay, thank you.
We have no further questions.
Thank you. The next section is really about the challenge of making an assessment. You have the participant in front of you and how to conduct an assessment without bias. One of the most important things that will help you in terms of determining whether or not something that a participant reports to you is indeed an adverse event or an untoward event that occurs during the course of the trial is to really do a thorough baseline assessment when you first, when you're spending the most amount of time with the participant, you're asking them a lot of questions, and that's a good time. It seems to be when most of the physical exams are done, the medical history is collected. You're asking about both a physical medical history and a psychological medical history for CTN trials, and that's where you want to try to collect all of this information and record it. And most of the CRFs and the progress notes, there's plenty of room to identify that type of a baseline history. One important thing to remember, though, is that, as we've mentioned before, just because someone has a positive finding at baseline doesn't mean necessarily that that is recorded as an adverse event. It's something that's recorded as a baseline event, and then if it worsens in intensity or severity throughout the trial, then it may become an adverse event. An example of that might be you have a diabetic who's on insulin, and they come in for their assessments, and that's not an exclusionary criteria. They're well-controlled diabetic. They're using their insulin as expected, and their blood sugar is under control. That's not necessarily, that is not at baseline an adverse event. It's something that's noted in their medical history. And then throughout the course of the trial, if their blood glucose levels start going out of whack and you notice that they are having difficulty controlling their blood glucose levels, and that's when you may take it the next step and report it as an adverse event. Because at that point it becomes something that's worsened. It was worsening from baseline to their current state. we talked about it in the first lesson about how some of the problems that come up when making assessments is how forthcoming the participant is with their symptoms and then or whatever events have occurred, and it's also how the clinician is going about asking whether or not anything's happened since the last visit. And so avoiding bias, of course, is not putting words into the participant's mouth of, have you been feeling sick lately, or has anything you've been doing in the last 2 weeks made you not feel good? You want to try to remain as objective as possible and ask them if anything has come up since their last visit. Using open assessment questions, open-ended questions instead of yes-no questions, things that encourage the participant to talk to you a little bit more. For instance, how have you been feeling since your last visit, or is there anything new you want to tell me? And that's why you want to avoid those questions that are a little leading, that may prompt the participant to say, actually, I have been feeling sick, instead of telling you specifically they had a headache on this date or they stubbed their toe on another.
We do have a question now.
Okay.
Caller, please go ahead.
Yes, my name is Susan. My question is, when you state that, positive findings on baseline should not be reported as AEs. In the case that you gave, the diabetic comes in and everything is fine. However, the diabetic says to you, and I have a headache today. Is that something then you would report the headache as the AE?
So is this at the baseline visit?
Yes.
So part of that would be characterizing the headache. So if the person says, I get headaches 3 days out of a week, and that's happened for the last year or so, and that's your baseline assessment, I would record that as part of the baseline history, not record that headache on that baseline visit day as an adverse event. If that person says, I never get headaches, and I've got this headache, they were consented into the trial, and you're doing a baseline assessment, then that would be reported as an adverse event because it's something different for them.
Great. Thank you.
And we have no further questions.
Okay, thank you. So it's important to probe for more information when there's a question. And again, trying to clarify the specific information and sticking to the facts. Asking the participant specific dates. When did this begin? What did you do to make it feel better? What made it better? What made it worse? What actions did you take? Did you take any medications? Did you seek medical advice? What did you do to make it better? And is the event still going on, or did it have an end date? Because you want to capture when it started, when it stopped, and what was going on around that time. Common roadblock in assessments is second-guessing yourself, because you start to think to yourself, is this related to the therapy, is this related to the intervention of the trial, or not? You really have to be careful to not let that affect your decision about whether or not you should report the adverse event. If the person says that they fell on the ice and hurt their elbow, then you have to pick out of that description what your verbatim will be. Pain, elbow pain might be the one that you choose, and you don't have to think about whether or not it's related. Clearly, it's not something that was related to the intervention at hand. It was something that was related to the person walking on ice outside, but it's still an adverse event that happened within the course of the trial. The same thing goes with expectedness. Unless the protocol excludes the reporting of that event, I'm trying to think of an example, and I'm running a blank, but if the consent says this drug may cause decreased appetite and you don't need to report it, then you don't have to report it. So always go back to your protocol to see what is reported and what isn't, but try not to let expectedness and relatedness affect your decision about whether or not you're going to report an adverse event. Lack of time spent on an initial assessment at baseline is definitely something that I see. I often, when I'm looking at an adverse event that's reported, I go back and I look at the medical history. When the monitors are at the sites and when we're at the sites looking through the progress notes, we're trying to determine, was this something that was reported initially? And sometimes it's because we're not asking the participants enough questions in the very beginning when the clarification is needed. Oftentimes, too, the participants come in and they're excited to see you, they're excited to share information with you, they tell you a lot of things that have been happening, and trying to sort through all of that sort of clinical drama and get down to the nitty-gritty of what the actual event was, it's hard to do sometimes. Again, they've got a lot to tell you, they're unloading all of this information on you, and you've got to break it down and pull out the actual events themselves and try to categorize them in very succinct ways. We pulled some actual verbatims that have been reported in the adverse event database. And these are only a few. And for the most part, the verbatim that we see are very, very well put. They're usually very appropriate and short and sweet. But these are some examples of just a few that we've run across that we thought would be good examples to go through with the group and sort of show the way that they were written and the way that they could possibly be improved upon. The first one, leg soreness from soccer. That's a fairly broad definition, I guess, a broad verbatim.
Well, it's also the from soccer is fairly irrelevant to what the adverse event is. So and that's where we put in some examples of possible verbatims. So leg soreness from soccer is a codable event because it would be coded for the leg soreness, and so this one is not too bad actually, but it's just where there's extraneous information. Right. Oftentimes using left or right is extraneous as well too, because it really doesn't make any difference if it's on the left side or the right side.
But asking someone to clarify a little bit more, just becoming accustomed to asking someone, is it painful? Is it a muscle strain? Is it a bruise? What is it? Just so that you can clarify a little bit more, pinpoint it a little bit more. The next one is another verbatim. And remember, we're trying to use 2 or 3 word descriptors here or phrases here, and this is one that's 2 sentences long. Got arrested for pushing mom while I was high. They just came to the house and talked. And again, this is a sort of a very vague, there's a lot of information in it, a lot of extraneous information, and probably could have really been boiled down to just a few words. Part of the problem with this is that, again, there's some drama on this. The participant was arrested, and this is, in their mind, a very substantial event. So they want to tell you about it. They're telling you that they got arrested for pushing their mom while they were high. So to improve on it, maybe focusing on the aggression, the pushing mom, and the intoxication or substance use, and not the arrest, and taking out the part that coming to the house and talking, again, not really part of the verbatim. Some of that may be okay in a progress note, but really not relevant to the adverse event. So focusing more on the aggression and the intoxication or substance use.
So this would be a tough event to code because when you code these events, the goal is not to interpret, and the only way you could code this event is to interpret this as meaning aggression, and that job is really at the site to make the best determination of what they feel the event is. And so this event may be split into 2 separate events. One would be aggression, one would be intoxication. If that was felt to be appropriate based off the description that you had, and looking at this verbatim, I could see splitting it that way. But it may be as you get more history and you unravel this event, there are better terms that could be used. But the expectation would be, a single item and 2 to 3 words to describe that single item. And so that's where getting, more history or narrowing it down or getting a better feel for how you want to report this event would be useful.
And thank you, Bob, because that's a really good point about the trying to get that feeling for it, as you said. I think I was struggling for that word of trying to interpret what the person on the other end is trying to say. And the person really who did that assessment is in the best position to state what the actual verbatim was. Here are a few more examples. Client started a fight at school today. He's been in multiple fights prior to entering the study. So this sort of leads us to believe that being in multiple fights prior to entering the study should be baseline information. And so the next question is this evidence of increased aggression? What was the basis for starting the fight? And again, this is something that 3 months down the road, when someone's trying to code this event, they have to make a lot of assumptions about it. And that's something that's much better done at the site when the initial event is reported as much as possible. And that can be done by trying to probe for a little bit more information. The last one, behavioral. Quit job, got angry at customer, broke up with abusive boyfriend, same day. Again, this is great information to know that all of these events happened to this participant. It does really characterize perhaps the mood that they were in that day, or just some really bad luck or bad things that happened in that particular day. But breaking it down and looking for a common denominator between all of these events, quitting their job, getting angry at a customer, breaking up with an abusive boyfriend, all in the same day. What happened? What was the catalyst? What are we looking for? And that's something, again, that is best made, with the judgment of the clinician or the assessor at the site. And that's something that's much better done at that time than several months down the road. This is something that I get questions on fairly frequently. And the verbatim in this case is menstrual cramps, which is actually an excellent verbatim. That's very descriptive of the adverse event that was reported by a participant. So when the assessor is asking the participant, has anything changed or anything happened since the last time you were here, and the person says, I've had some really bad menstrual cramps. So the question is, does this need to be reported? Is this an adverse event? And I get this question all the time, and it's a good question. But the question is really, is this their baseline condition? Is this something that has worsened because of the participant's involvement in the clinical trial? Prior to being in the trial, did they have menstrual cramps? Was this their baseline, and has it gotten worse since they've been involved in the trial? Or is just this a normal progression of events? So that's a good verbatim, but it really doesn't need to be reported as an adverse event unless it's something that's worsened since they've been active in the trial. The last one on this slide is diagnosis unknown. Symptoms include ear infection in both ears. And in this case, diagnosis unknown is really irrelevant. The ear infection in both ears is really capturing the adverse event, and that's all that really should have been reported in this case. So we'll go through some polling questions. A good baseline assessment is critical to determining future adverse events. Okay, great. Looks like everybody got that one. Next question. Unrelated adverse events do not require reporting. Okay, we can go on to the next question. Asking open-ended questions is useful when gathering information about an adverse event. Great. Next question. Participant reports sweating and vomiting since the last visit. What is the adverse event? So this is a little tricky because people are telling you two very specific things. And most of you seem to think that probing further would be a good idea. I think so too. I think asking a few more questions. Next question. So you prompted the individual for clarification, and the participant said, well, I think it must have been something I ate. When I woke up the next morning, I was fine. So now what would you categorize as the adverse events?
Maria, let me skip back one. I think I skipped a...
Oh, okay.
Oh, no.
We're good.
No, we're good. Sorry.
So the question is relating to the prior question about the stomach ache and sweating. The person, you've asked for a little bit more clarification, and the person says, it must have been something I ate. When I woke up the next morning, I was fine. Going with that information, what would you say the adverse events are, or is?
So this could be an area where, again, as you're gathering information, if it was something they ate, maybe you would consider it food poisoning, which would then combine the vomiting with the perspiration as sort of a combination event. If you believe that based off their history, that's sort of consistent with it, and so you'd use the diagnosis. If you're not convinced that that's an appropriate diagnosis based off what they tell you, you may keep it in symptoms, which would be the vomiting and the increased perspiration, in which case you would split that into two separate adverse events, one for perspiration, one for vomiting. And that's what makes a diagnosis attractive, because it's more encompassing in terms of the symptoms that are associated with that diagnosis without having to report each individual symptom. But you can't always do that based off the information that you're given as well.
Okay, next question. So a participant comes in to see you, and they're holding their stomach and looking queasy. And you ask them how they're feeling, and they say, well, I think it's something I ate at Taco Bell. We must be hungry. I don't know. So how are you going to report this adverse event? So you're using your eyes and your ears. They're telling you something, and you're observing a behavior.
And we do have a question.
Sure.
Okay, one moment. Caller, please go ahead.
I retract the question. It was answered.
Okay.
So this verbatim was actually put in as upset stomach, I ate at Taco Bell. So that's the actual verbatim we saw in the system. But the choice of stomach ache would be grade or gastritis, or it could be a lot of different terms. All of those are very codable terms.
Even upset stomach probably would have been
yeah,
okay.
No, and that's codable too.
Yeah.
The Taco Bell is just extraneous information.
Okay, next question.
Okay, we'll return to the presentation.
Thank you.
Okay. So I've identified the adverse event. Now what? So, you know, one thing that I want to sort of reiterate based off of what Maria just presented is there's sort of two steps to adverse event reporting. One step is to identify the event, and that's where you get your baseline history. That's where you ask open-ended questions, and then you know, you identify the event. What you dissociate from that identification is the characterization of the event, which is what I went through. Because one of the pitfalls for identifying the event is clinically you characterize it before you identify it. So you're sort of thinking about this as an event, and then your brain just clicks into, oh, well, this is expected, oh, this isn't related. And so then you make decisions not to report it because you believe it's unimportant. If you truncate that process, identify the event as just it occurred or it didn't occur, it makes it much easier, and then after you've identified it, it's recorded, and then you characterize the event to your best belief in terms of the severity, the relationship, and what you're going to call the event. So how does the adverse event data go into a safety database? Documenting it in succinct rules or accurate documentation, then rules for reporting. So you've identified the adverse event. Now what do? So you identify it, you put it into the data system. So that's direct data entry. You have your progress note where you've described what happened, you put it in the data system, and then you characterize it in the data system. Again, you want the verbatim short, 2 to 3 words, and accurate for what the person described to you. After you enter it, you characterize it. What's the relationship to the intervention? What's the severity? Does it qualify as a serious adverse event? Serious adverse events must be entered within within 24 hours of you becoming aware of the event. So let's say somebody comes in and they said, "Oh, I was hospitalized six months ago." You first became aware of it when they told you that, even though the hospitalization occurred 6 months ago. So that's perfectly acceptable, and that's when you report the event. What's not acceptable is for them to have told you they were hospitalized 6 months ago and you enter it 6 months later. So once you find out about it, you're obligated to get that event put into the data system. So the adverse event number on the electronic case report form should be entered on the serious adverse event form for linking purposes. So this is just, there's an adverse event form, serious adverse event form. Obviously, because the adverse event and the serious adverse event are in fact the same event, it's just characterized as being a serious adverse event, and it's recorded on 2 separate forms. Both the number and the name must carry through because it's all one event. It's just reported with certain information on the adverse event form and other information on the serious adverse event form. So what happens to the AE/FCE data? Most of the protocols or the manuals of procedures have schematics for what happens and making choices. I'm not going to go through this, and that's all sort of available information in terms of the process, the timing, who looks at what. So this is sort of one of my famous light bulbs. If the assessment wasn't documented, there's no evidence that it was done. This is sort of a mixture of things, because typically what we find when we monitor is that the assessment was actually documented in the progress note, but it wasn't entered into the database. But if it's not in the database, nobody knows about it. So it's critical for documentation to occur in 2 places. One is your progress note, where it's your source document and where you take your history and that type of thing, and then that the events that are identified in that progress note are entered into the database. So who receives safety reports? So IRBs receive it as required by your site IRB, but they are responsible for research being done at any given institute. So for the protocols that you all be working with CTN, there will be an IRB that is responsible for your site that has jurisdiction over the safety and the conduct of the clinical trial at your site. Now, in the CTN program, there's also a DSMB as well, too. So now there are 2 levels of reporting. There's the IRB and the DSMB. And then for studies that are under IND, there may be 3 levels of reporting, where there's still the IRB, there's also the DSMB, and then the FDA as well, too, for the IND studies. So what does the IRB see? What sort of information? Essentially, they see anything they want to see, and you'll see that sort of recurring theme. They're sort of catchword for what they want to see right away or unanticipated problems. And these can be sort of the concept of serious adverse events that require a change in the protocol or the consent. It can be medication errors that are made, protocol violations. So each IRB will have their rule set of the type of information they want to see from your site. It doesn't mean they want to see it across the entire study, though some IRBs request that type of information, and they're provided information that the study was reviewed by a DSMB and no safety concerns were found, or some other type of information. And IRBs have yearly reviews where they renew their approval for the protocol to be implemented at the institution that they're overseeing. So what does the DSMB want to see? They also want to see anything they want to see. They basically are looking at safety information, they're looking at data integrity, and they're looking for the protection of participants in the trial, somewhat similarly to the IRBs. So they're looking at the clinical trial across all the sites. So they have pooled data across the sites. And this is where, when they review safety information, they are reviewing the adverse events that you've reported that have been MEDRA-coded because the verbatims were 2 to 3 words long and just looked beautiful, and they were MEDRA-coded successfully and created nice reports for the DSMB. So they are interested in seeing events, safety events that occur that are typically serious, related to the intervention, and unexpected. And that's where this characterization of adverse events becomes important, because it sort of determines the timing at which a DSMB or FDA under IND studies, and even the IRB, will be interested in looking at events. Do they want to see them at the end of the year, or do they want to see them earlier? And this designation of something that's related and unexpected is something that's in the federal regulations for IND studies, but that is still down to DSMBs typically, and somewhat to IRBs, though they use this unanticipated problem designation, but it still essentially covers this concept of serious, related, and unexpected. So those determinations become very important in terms of the characterization of the adverse events that are reported. And then yearly, the DSMB will see a listing of all adverse events, or a summary of the adverse events that have been reported in the various treatment groups, and a summary of the serious adverse events that have been reported. And so finally, FDA, what do they want? They want anything they want to look at, and that can vary depending on the studies. I have, some protocols where they want to see all serious adverse events, regardless of if they're related or unexpected or not. The regulations specify serious, related, and unexpected, and this includes deaths and life-threatening events as well, too. So if you have death that occurs in the study, but it's considered unrelated to the intervention, that would not require an expedited report. Though in many trials, those events are sent to the FDA just essentially as a precautionary thing or as an informational type of thing, though the regulations don't specify that it has to be sent in. And the regulations really specify the minimum reporting requirement. You have the option to report more than that if you choose to do that. And FDA, like DSMB, will see a summary of all safety events on a yearly basis, and that's the FDA IND annual report that's sent in. So the FDA and DSMB are fairly similar in terms of the types of information they're reviewing, where they look at it across the entire study. FDA has the advantage to see things across multiple different studies from multiple different sources, and so they have a much larger safety data pool than a DSMB would, where they would have review sort of privileges or rights over a single study. But the DSMB has a broader view of what's going on from a safety perspective than the IRB, which is really responsible for the research at a given institution alone. So it's important that you know at each individual site what your IRB reporting requirements are, and that you follow the applicable reporting requirements. If you're in an IND study, then there are reporting requirements for an IND study, and timeliness is critical for that. So for IND studies, serious, unexpected, and related events require a 15-day report by hard copy. If the event is a death or life-threatening event, and unexpected and related, that should be sent into FDA within 7 days by fax and followed by a hard copy in 15 days. These are specified in the regulations, and it's important that they're maintained, which is why serious adverse events need to be reported in the data systems within 24 hours, so there's an opportunity to respond to these timelines that are specified in the regulations. Again, these regulations are IND studies, though the DSMB typically follows a similar pattern in terms of their expectations of timing of events as well. So we'll flip to a couple polling questions. So all adverse events and serious adverse events must be reported in the data system. That's good, and we can go to the next one. An adverse event which meets the definition of a serious adverse event must have a different name associated with it in the data system. So this one is where I described within the data system that we use for CTN, adverse events and serious adverse events are recorded on 2 separate electronic case report forms, but those forms must link where they have the same number and the same adverse event name or verbatim. And that's, again, another reason why it's good to have a short verbatim so you don't have to write as much on the second page when you enter more information. Next one. The only events reported to IRB or DSMB or FDA are expedited reports. So the reason this question is in here, and it's true, it's false, is when we talk about expedited reports, there's a lot of hoopla associated with that, and everybody gets anxious about it. FDA and DSMBs see all safety events, but they see it in a summary basis on an annual report. The only thing they're interested in an expedited report are things that fall outside of what they sort of expect, and that's why it would have to be an unexpected event and also considered related, because that keys them into this is something that the investigators feel is a little bit unusual from what they thought was going to be occurring in this study, and it's something we should probably take a look at. Next. Okay, so if there are any questions, I could take a quick question. We've only got about 8 more minutes left, and the last section is only a couple slides, so we should be able to finish up on time. But if there are any questions, I'll take those.
Once again, ladies and gentlemen, please press *1 if you would like to ask a question. We'll go ahead and take our first question. Caller, please go ahead.
Bob, this is Paul. I have a question about, we've talked about, these AEs and SAE being reported during the course of the trial, and we talked about baseline and the headache example question about what about the headache during baseline. I guess my question is, when does the course of the trial technically start and when does it end?
Well, that's a good question. There's obviously a lot of controversy about that, which is why there's a question, too. Most people will consider from a clinical trial standpoint, the time you sign consent to participate in the trial to the time essentially the study's over. And sometimes that study over is extended for 30 days as well, so that if adverse event or serious adverse event occurs in the 30-day window, especially in a medication trial where the medication ends and the trial's over, there's a 30-day window where events are reported as well, too. So that gets into sort of a general time period for adverse event and serious adverse event reporting. There's another designation, which we did not discuss in here, which are called treatment emergent adverse events, or TEAEs. And those are adverse events that occur after the intervention has been initiated. So there's usually a window between when consent is signed and when intervention starts, and that could be baseline assessments, that could be a whole bunch of things, but they never got to study intervention, whether it's a drug or behavioral intervention. So events that occur in that time are typically reported, but they're not reported in what would be called a treatment emergent adverse event database, where it's events that have occurred after the onset of the initiation of therapy. So that's generally how that's differentiated. Again, protocols have some flexibility to say that we would not capture adverse events in that window between consent and initiation of therapy, but maybe we capture serious adverse events. Some protocols have significant screening procedures as well that occur after consent is signed, or other types of procedures that are protocol related that may put participants at risk. And those events, even though the true intervention hasn't started, it was their participation in the trial that could precipitate serious adverse events as well. So I think you have to look at the individual protocol, and you just have to be clear in the protocol when your time periods are starting and your expectation for the types of events to be reported in those time periods.
Thank you.
So that kind of brings us towards the end with the Lesson 6 follow-up. And that was a good lead-in. Thank you, Paul. For study-related adverse events have to be followed through resolution or stabilization, even if this is beyond the end of the study. And again, that's for that 30-day period, and it's usually specified by the protocol itself. But a common time period is 30 days after the study is ended. Pregnancies, of course, we mentioned earlier, are treated more like serious adverse events, even though they're not reported as such, but keep them in sort of the same category in that they need to be followed until an outcome is reached. And that could be an outcome, as I mentioned, such as miscarriage, an abortion. It could be quite a few different outcomes that occur, but if the participant becomes pregnant during the course of the trial and they don't deliver a baby until 9 months later, we have to anticipate that has to be followed through until that outcome is reached and the baby is assessed, and we're sure that there are no congenital anomalies or birth defects as a result of the participant being in the trial. Serious adverse events, related and unrelated events, have to be followed until resolution or stabilization, again, even if that's beyond the end of the study. Unrelated adverse events have to be followed until resolution, stabilization, or study end as well. The site staff must contact study participants 30 days after the end of the study in order to do a final adverse event assessment and to follow up on events that were continuing at the end of the study. So, again, this is something that's written into most protocols, but there is a follow-up period in which the staff has permission to contact the participant. Oftentimes it's written into the consent forms that allow the staff to continue follow-up with the participant after the end of the study and to close out those events. When assessing for adverse events, always remember developing a site-specific system for tracking adverse events. So coming up with a process that works at your site is the most important thing. Figuring out how you're going to use those adverse event CRFs or your progress notes in order to check for unresolved adverse events from previous visits prior to the participant coming in for that day. It could be some sites have come up with adverse event logs that they keep in the beginning of a participant's binder, and they continue to move that throughout the binder. Some sites continue to move the case report form to try to remember to assess the adverse events at each subsequent visit until resolution. But you always want to follow up on those unresolved AEs before assessing for new ones. And on that note, we'll close with some last questions. Adverse events require follow-up until resolved or stable. Okay, great. We can move on to the next one. So the answer to that was that's true. They do need to be. Follow-up of some events may extend beyond the end of the study. Great. Again, that answer is true. They do need to be followed up until the end of study.
So one other comment that I would make as well, too, is that sometimes when we look at adverse events here, because once you report them, we look at them, and especially for the serious adverse events, sometimes we'll go back to the site to ask additional questions for clarification. Again, our belief is the site is the best position to make assessments, though based off the history we get here, we basically ask for clarification for that assessment. What's the justification? What's the rationale? Because it's not apparent in the information that we have here. So especially with relationships, somebody may consider this related to the intervention, but it seems sort of discordant, or it doesn't seem temporally related, or we don't have a sense for why that would be the case, or it might be considered expected or unexpected or something. So sometimes we'll query sites back to just get a little bit more information to understand the thought process, because remotely we're disconnected from that, and usually the explanations will make sense. I don't know if you remember the eye picture at the beginning of this study, but they were nice and bright and wide open, and I'm sure this is what they look like now for most of you. But what we tried to do is review monitoring, overview of safety, adverse event versus serious adverse event, characterizing adverse events, assessment process, documenting and reporting adverse events, and then follow-up. And I think that's the last of our slides. So Liz, I don't know if you have any. We'll certainly take any questions. It's 4 o'clock right now, so I'm sure people are getting ready to go on the East Coast at least, or thinking about it. If there are any questions, I'd be more than happy to entertain that. And Liz, I don't know if you had any other.
I do have a couple closing announcements I'd like to make. An evaluation form will be distributed to everybody. We're distributing that under a new format. It's a survey done online, so it should be a lot easier to fill it out, and we welcome any kind of feedback we can get from you. Our next web seminar will cover informed consent and be held on July 24th at 2 p.m. Eastern Time. Did anybody have any questions at this time?
Once again, if you do have a question, that is *1. We'll go ahead and take our first question. Please go ahead.
Hi, this is Christy at UCLA, Bob and Maria. I just have one question for you.
Sure.
Can you discuss how AEs that change in severity are to be documented? So, for example, an AE is initially reported and characterized as mild, and upon a second assessment later down the road, the participant reports that it worsened, and so maybe they took a concomitant medication for it, and so now it's a moderate event. So do you foresee that being captured as 2 events, one that closes at the mild severity and then reopens for moderate, or can you talk about what your expectations are with regard to that?
Yeah, I mean, that gets into a data question as well, too, that I actually will have to get back to you on. In general, an event is a single event, and so the CTC AE describes that scenario by saying that the event should carry the most severe grade with it. And so if you start off with an event that's characterized as mild and a week later it's ongoing, but now it's moderate, you switch mild to moderate, and that becomes the severity that stays with that event. If the event then is still ongoing at the next visit, but now it's mild again because it's really improving, you still leave it as a moderate event because that's the worst grade that occurred during the course of that event, and if the event resolves, then you put in the resolution date when it resolves. So events are single events even if they change severity grading. I have seen data systems where they close out the event at the mild and then reopen the event at a moderate level, and so then you're getting 2 events that are sequential. So the same thing, like a cholecystitis would be reported as a moderate event, and then a week later, now it's severe. It would be closed out as moderate, re-entered as a severe event. So then you have to look at that sort of temporally to understand it's only a single event and not an event reported twice in the study. So that's why generally we'll just change the severity grading, leave it as a single event. I don't know if from a data capture standpoint that there are special rules within the user guides for reporting of that. And maybe you know from...
that was part of the reason why I asked the question, because I've seen it done differently on different protocols, and so I just wonder from your experience what you had seen or what you thought was preferable in that regard.
Yeah, I've definitely seen both done.
Yeah.
Preferably, I would do single reporting, change the grading, and that's sort of consistent with the instructions in the CTC from the NCI as a reporting strategy. But I think that's exactly what it is. It's a strategy. The risk doing it the other way is over-reporting certain events because they're recorded 2 or 3 times in the database, and so it falsely elevates the number of those events that have been reported unless you're diligent for eliminating the duplicates.
Great. Yeah, that's been my experience, too. Thank you so much. I appreciate that.
And it appears we have no further questions.
Okay, well, I think we're done then. So thanks, everybody.
Thank you.
Thank you. Ladies and gentlemen, this does conclude today's teleconference. We appreciate your participation. Have a wonderful day. You may now disconnect.